Hello, it's Dmitry again. Today we'll be going back to Blueprints Psychiatry, Chapter 13 now, for mood stabilizers. Again, we're reading from the 5th edition of the Blueprints Psychiatry textbook. If you're using the newer edition, there will be some differences between the content here and the content presented there, presumably, and some organization differences in terms of the chapters, although the content overall is relatively similar to my knowledge. Anyway, so let's begin. Chapter 13. Mood stabilizers. Mood stabilizers are psychotropic medications that promote euthymia, a normal, non-depressed, reasonably positive mood in bipolar disorder. They generally treat and prevent the recurrence of elevated or manic or depressed moods. The term mood stabilizers traditionally refers to lithium, valproate, carbamazepine, and lamotrigine. More recently, it has been proven that some atypical antipsychotics have mood stabilizing properties, meaning that they are able to treat and prevent the recurrence of manic or depressed phases of bipolar disorder. This capacity was discussed in Chapter 11. Table 13.1 lists the traditional mood stabilizers, their dosage, and therapeutic levels. Indications. Mood stabilizers are indicated acutely in conjunction with antipsychotics for the treatment of mania. They are indicated for long-term maintenance, prophylaxis against depression and mania in bipolar individuals. Anticonvulsant medications, valproate, lamotrigine, and carbamazepine may also be useful in individuals experiencing seizure-related mood instability. Mood stabilizers are also used for treatment of impulsive behavior in individuals without bipolar disorders. The choice of mood stabilizer is based on a patient's particular psychiatric illness, that is to say, for example, subtype of bipolar disorder, and other clinical factors such as side effects, metabolic routes, patient tolerance, and the history of a patient or first-degree relative drug responsiveness. Table 13.2 lists the major mood stabilizers and their most common indications. Some common and more serious side effects of mood stabilizers are listed in Table 13.3. The mechanism of action of mood stabilizers in bipolar illness is unclear. The range of neurotransmitters affected by these medications and their disparate modes of action suggest that mania may be controlled by altering the function of several different neurotransmitter systems. Conversely, they may share a common mechanism of action that is yet to be elucidated. So let's start off with lithium. So lithium mechanism of action. Lithium's mechanism of action in the treatment of mania is not well determined. Lithium alters at least two intracellular second messenger systems, the adenyl cyclase, cyclic adenosine monophosphate system, and the G-protein coupled phosphoinositide systems, and as an ion can directly alter ion channel function. Because norepinephrine and serotonin in the central nervous system, CNS, uses G-protein coupled receptors as one of their mechanisms of action, their function is altered by lithium. Lithium also alters the gamma-aminobutyric or GABA metabolism. Choice of medication. Lithium is indicated as a first-line treatment for regular cycling bipolar disorder in individuals with normal renal function. Lithium is also used to augment other antidepressants in unipolar depression. Lithium is renally cleared and can easily reach toxic levels in persons with altered renal function, that is to say, especially elderly individuals, or dehydration. It may be less effective in the treatment of rapid cycling variant of bipolar disorder. When used in the treatment of bipolar disorder, lithium has been shown to reduce the incidence of completed suicide. Table 13.1, common mood stabilizers. We have the drugs, starting dose, therapeutic dosage, and the therapeutic serum concentration. So we have lithium carbonate. Starting dose will be 300 milligrams, twice a day, thrice a day. Therapeutic dose is 900 to 1,500 milligrams a day, and the therapeutic serum concentration would be 0.6 to 1.1 milliequivalents per liter. For valproic acid, it's 250 for starting, 1,000 to 2,500 for 1,000 to 2,500 for therapeutic dosage, and then 50 to 125 for the therapeutic serum concentration. Lamotrigine, starting dose would be 25 milligrams once a day. The therapeutic dose would be 150 to 250 milligrams a day, and they don't give you a therapeutic serum concentration. Now, carbamazepine is 100 milligrams as a starting dose twice a day or thrice a day. Therapeutic dosage is going to be 600 to 1,200 milligrams a day, and the therapeutic serum concentration will be 4 to 12 milligrams per liter. Oxcarbazine is 150 milligrams twice a day for starting dosage, and then you will get to 600 to 1200 milligrams a day for therapeutic dosage. It says here, dosages are generally lower for geriatric patients, patients taking medications inhibiting the metabolism of the drug, or patients with other medical problems. Table 13.2, psychiatric indications for mood stabilizers. So for the drug and then the uses. So lithium, you can use it for acute mania, bipolar depression, long-term maintenance in bipolar disorder, augmentation of antidepressant medications, and impulse control. For valproate, you can use valproate for acute mania, long-term maintenance in bipolar disorder. It may be more effective in rapid cycling bipolar disorder. It also is used for impulse discontrol. What about carbamazepine? Well, carbamazepine can be used for acute mania, long-term maintenance in bipolar disorder, and impulse discontrol. What about lamotrigine? Lamotrigine can be used for bipolar depression, and it can be used for long-term maintenance in bipolar disorder. And there's a little note here that says some indications are Food and Drug Administration approved, others are based on clinical experience and evidence. And that's an important thing to note that, well, first off, this is an older edition, so it might not be what is FDA approved then might be more expansive now, because there might be some new approvals and stuff like that since then. Beyond that, I would say that there is a disparity between, or there's a little bit of a chasm between what is FDA approved and what is used by doctors off-label based off of clinical experience and what literature there is out there on the subject, even if it is not necessarily FDA approved as of yet. So, bear that in mind. Therapeutic monitoring. Successful lithium therapy requires that the patient take daily dosages of the drug consistently. The therapeutic effect generally occurs after 2 to 4 weeks of consistent use. Serum levels should be monitored regularly until a stable dosing regimen has been obtained. Additional monitoring is necessary in a patient with variable compliance or altered renal function. In addition, patients should be warned about toxicity and should be regularly assessed for side effects. Approximately 5% of patients on long-term lithium therapy develop hypothyroidism because the lithium interferes with thyroid hormone production. Serum thyroid-stimulating hormone and creatinine levels should be checked at regular intervals. Lithium has a narrow therapeutic window, and patients can develop toxicity at prescribed doses, especially if they undergo an abrupt change in renal function. And so some side effects for lithium, we're talking common side effects of lithium therapy include tremor, polyuria, excessive thirst, GI distress, minor memory problems, acne exacerbation, and weight gain. At toxic levels, though, it can cause ataxia, coarse tremor, diarrhea, confusion, coma, sinus arrest, and death can occur. What about valproate? Valproate is another one of these mood stabilizers. Mechanism of action for valproate. Well, valproate's mechanism of action is thought to be due in part to augmentation of GABA function in the CNS. Valproate increases GABA synthesis, decreases GABA breakdown, and enhances its postsynaptic efficacy. Table 13.3, drugs used as mood stabilizers. So here's the drugs and here's the side effect profile. So lithium, so let's talk about lithium. Therapeutic levels, okay. At therapeutic levels, lithium can cause sleepiness, sedation, cognitive clouding, and fine tremor. For endocrine issues, it can cause abnormal TSH, clinical hypothyroidism. Cardiac can cause T-wave changes, sinus arrhythmia. Renal can cause polyuria. Dermatologic can it can exacerbate acne and psoriasis. GI, it can cause nausea, vomiting, and diarrhea. For hematologic, it can cause benign leukocytosis. In others, it can cause weight gain. Other things can cause weight gain and fluid retention. Now, if it's toxic, in the CNS, it can cause ataxia, tremor, confusion, seizure, coma, and death, which is pretty serious stuff. For cardiac, it can cause sinus arrest. So bear that in mind when we're talking about toxic levels versus therapeutic levels for lithium. And lithium, again, there's a very broad range of things that can cause across the body. The central nervous system, endocrine system, cardiac, renal, very broad. What about valproate? We were talking about valproate just a minute ago. Valproate therapeutic levels for CNS can cause somnolence, ataxia, and tremor. And this is in therapeutic levels, by the way. It can cause ataxia, potentially. Endocrine can cause menstrual irregularities, thyroid abnormalities, Dermatologic can cause alopecia and rash. Hepatic can cause mild transaminitis. GI, valproate can cause nausea, vomiting, and indigestion. Hematologic can cause thrombocytopenia and platelet dysfunction. Other effects that could cause edema. Now, if toxic levels of valproate can cause in the CNS ataxia, confusion, coma, and death. Cardiac can cause cardiac arrest. Now, idiosyncratic for the valproate, the hepatic would cause fatal hepatotoxicity. GI can cause pancreatitis, and the hematologic can cause agranulocytosis. What about carbamazepine? Therapeutic levels of carbamazepine in the CNS can cause ataxia, sedation, dizziness, and diplopia. Dermatologic can cause rash. Cardiac can cause decreased AV conduction. Hematologic can cause benign leukopenia. The GI can cause nausea. Now, toxic levels of carbamazepine in the CNS can cause somnolence, autonomic instability, coma, and death. Now, coma and death seems to be a pretty recurring thing for these sort of toxic levels of these drugs. Cardiac can cause AV block. Respiratory can cause respiratory depression. For the idiosyncratic levels of carbamazepine, it can cause hematologic issues with granulocytosis, pancytopenia, and aplastic anemia. What about lamotrigine? Lamotrigine at therapeutic levels for CNS can cause dizziness, anxiety, insomnia, somnolence, coordination abnormality, and headache. For the endocrine, it can cause dysmenorrhea. For cardiac, it can cause chest pain. Dermatologic can cause rash or serious life-threatening rash. Okay. GI can cause nausea, vomiting, and dyspepsia. Other, it can cause weight decrease. Interesting. For lamotrigine, it can cause weight decrease, an infection, or rhinitis. What about toxic levels of lamotrigine? What can cause ataxia, nystagmus, seizures, coma, and death? Okay. Cardiac can cause intraventricular conduction delay. Now it says here CNS means central nervous system. Yes. Okay. Now back to the valproate. For valproate, mechanism of action, the last sentence I want to put on mechanism of action for valproate is that its capacity to raise the seizure threshold allows it to be used to treat seizure disorders as well. Okay, so basically it actually increases the seizure threshold, and that will allow it to actually help with that as well, potentially, for carbamazepine, for valproate. Now, choice of medication. Valproate is indicated for the treatment of acute mania and is widely used in the maintenance phase of bipolar I disorder. Table 13.2. It is effective for the rapid cycling and mixed variants of bipolar disorder. It may not provide prophylaxis against depression and bipolar disorder or augment antidepressants. It is used off-label for treating general impulse discontrol, as we were talking about before. So it's good to know, exactly what are these different drugs used for, how do they work, and what are the side effects. So when you have a patient question, or even if you're in real life, obviously, but if you have a question on the exam, and it says, okay, this patient is like this, this, and this is, you have to figure out based on the description, what is their condition, and therefore, what drugs can you use to treat that, and also think, furthermore, what side effects do these drugs cause, and how do they work? So, because you might get a question about how does that drug work. You might get a question about how this patient had a side effect from a drug they were taking for this condition like bipolar or whatever. You have to ask yourself, okay, what kind of drugs should you possibly use for that in the first place? That kind of thing. Therapeutic monitoring. In otherwise physically healthy adults, valproate can be initiated at a larger than usual dosage, 20 to 25 milligrams over kilogram body weight. For the acute treatment of a manic episode known as a Depakote loading, in the acute hospital setting, this allows for rapid achievement of a therapeutic blood level. A lower average daily oral dosage is then started the day after loading. Rapid, less than 7 days decreases in manic symptoms can be achieved with this method. The full effect of the medicine is generally not seen until 2 to 4 weeks of consistent daily dosing at a therapeutic level. Serum levels should be monitored regularly until a stable blood level and dosing regimen have been obtained. Liver function tests should be checked at baseline and frequently during the first 6 months, especially because of the idiosyncratic reactions of fatal hepatotoxicity is most frequent in this time frame. Okay. So just be aware of that. Side effects of valproate. At therapeutic levels, valproate produces a variety of side effects including sedation, mild tremor, mild ataxia, and GI distress. Thrombocytopenia and impaired platelet function may also occur. At toxic levels, valproate can cause confusion, coma, cardiac arrest, and death. Valproate usage carries with it the risk of idiosyncratic but serious side effects. These include fatal hepatotoxicity, fulminant pancreatitis, and agranulocytosis. What about lamotrigine? Lamotrigine, mechanism of action of lamotrigine in bipolar disorder is unknown. Lamotrigine is approved by the FDA for the use in the maintenance of depressed phases of bipolar I disorder. Lamotrigine is not approved for the acute treatment of mania because it appears to be less effective in this phase. So it's really just for the depressive episodes. Lamotrigine in vitro has been shown to inhibit the voltage-sensitive sodium channels. This effect is believed to stabilize neuronal membranes and modulate presynaptic excitatory neurotransmitter release. So they just said, we don't really know the mechanism. They start talking about the mechanism right here, talking about stabilize neuronal membranes and modulate presynaptic excitatory neurotransmitter release. So they kind of have some hints at it. Now, this is a book from way back when, so I figured it might be a good idea to just actually check lamotrigine mechanism right now, because there might be some more information that we know now in the last 10 plus years. What it says here, lamotrigine stabilizes presynaptic neuronal membranes and prevents the release of excitatory neurotransmitters. So basically kind of what they said before. Most notably glutamate. It achieves this by inhibiting the voltage-gated sodium channels and interfering with voltage-dependent calcium channels such as the N- and the N type and the P type, ultimately dampening neuronal excitation. Okay. So let me just read out a little description right here for you. So for lamotrigine, sodium channel inhibition. Lamotrigine selectively binds to the inactive voltage-gated sodium channels, preventing them from reopening. This slows down the repetitive high-frequency neuronal firing. Glutamate reduction. By stabilizing the neuronal membranes, it suppresses the presynaptic release of glutamate, the primary excitatory neurotransmitter in the brain linked to both seizures and mood cycling. Calcium channel modulation. It also inhibits the voltage-gated calcium channels, further dampening the release of excitatory amino acids and the receptor effects. Unlike many other psychiatric or anti-epileptic medications, lamotrigine does not significantly interact with GABA, dopamine, or serotonin receptors. So it's a little bit weird, But we have some idea as it stands right now about how it works. Choice of medication. Although studies are still ongoing regarding the use of lamotrigine in bipolar disorder, it appears to be more effective in treating or preventing the depressive phase of bipolar I disorder than the manic phase. It may be more efficacious for rapid cycling. Dosages are started low at 25 milligrams daily and increase gradually 25 milligrams per week to the average therapeutic dosage of 200 milligrams daily. Dosages are generally lowered for elderly individuals, those with renal or other organ impairment, or when combined with interacting agents, that is to say, for example, valproic acid. Therapeutic monitoring. Therapeutic effect of lamotrigine is delayed by the need to gradually increase the dosage to a therapeutic level. The benefits are usually seen when the dosage exceeds 150 milligrams for 2 to 4 weeks. The development of serious allergic reactions, such as is a rash leading to Stevens-Johnson syndrome, to lamotrigine appears to be related to a rapid dose escalation or dose interactions. A clinically useful assay for serum levels of lamotrigine is not available. Generally, this medication should only be prescribed by a qualified psychiatrist, neurologist, or other provider who is aware of the complex drug interactions that exist, particularly between valproic acid and lamotrigine. Side effects of lamotrigine. We're talking a little bit about that right now, but lamotrigine can commonly cause ataxia, blurred vision, diplopia, or double vision, right? Dizziness, nausea, and vomiting. Severe, potentially life-threatening allergic rashes have been reported with the use of lamotrigine. The allergic reaction can begin as simple as a rash and lead to Stevens-Johnson syndrome. The rate of serious or life-threatening rashes is greater in the pediatric age group. And what about carbamazepine? Carbamazepine mechanism of action. The mechanism of action for carbamazepine in bipolar disorder is unknown. The carbamazepine blocks sodium channels in neurons that have just produced an action potential, blocking the neurons from repetitive firing. In addition, carbamazepine decreases the amount of transmitter release at presynaptic terminals. Carbamazepine also appears to indirectly alter central GABA receptors. So they say, we don't know the effect, how it works in bipolar disorder, bipolar illness, and they give us some mechanism stuff regardless. of course, we'll just check it right now to see what they might know now, which might not be the same as what they knew back then. Basic search says here, carbamazepine primarily works as a voltage-gated sodium channel blocker. By binding and stabilizing the inactivated state of these channels, it prevents the rapid repetitive firing of action potentials. This stabilizes overactive nerve membranes, which stops the spread of seizure activity, and it relieves neuropathic pain, such as trigeminal neuralgia. That is, okay, that's fair. That's another thing you have to be aware of, that trigeminal neuralgia is another thing that you treat with carbamazepine. It's also used as a mood stabilizer and anticonvulsant. So, yes, it has a calcium channel modulation, it does GABA enhancement, and it is also involved in serotonin turnover. It is thought to influence the turnover of noradrenaline and serotonin, providing additional mood stabilizing properties. Now, for GABA enhancement, obviously, it says it acts as a GABA receptor agonist, boosting the activity of the brain's primary inhibitory neurotransmitter. This produces calming, sedative, and anxiolytic or anti-anxiety effects. For calcium channel modulation, it reduces the influx of calcium into synaptic membranes, which helps dampen the release of excitatory neurotransmitters. So, yeah. So we kind of know a little bit of that before, and I guess I just know a little bit more now as it stands. A little bit more of a hard picture, I suppose. A little more, better foundation now, I suppose, about that. Choice of medication. Carbamazepine is generally considered to be an off-label, not FDA-approved, second-line drug after lithium and valproate for the treatment of mania. It is used in acute mania, prophylaxis against mania and bipolar disorder, and may be more effective than lithium in rapid cycling and mixed mania. Carbamazepine's efficacy in the prophylaxis and treatment of depression is not clear. It is also used in the treatment of impulse discontrol. Therapeutic monitoring. The therapeutic effects of carbamazepine are seen from 2 to 4 weeks after consistent daily dosing. Carbamazepine levels should be monitored regularly until a stable dosing regimen has been obtained. Patients should be carefully monitored for rash, signs of toxicity, evidence of severe bone marrow suppression. Side effects of carbamazepine. At therapeutic levels, it produces similar CNS side effects to lithium and valproate. Nausea, rash, and mild leukopenia are also common. At toxic levels, though, it can cause autonomic instability, AV block, respiratory depression, and coma can occur. Carbamazepine has idiosyncratic side effects of agranulocytosis, pancytopenia, and aplastic anemia. Okay, oxcarbazepine. Okay, oxcarbazepine is an anticonvulsant that is structurally similar to carbamazepine. I guess that's why the name is relatively similar, but that has fewer side effects and drug interactions. The efficacy of carbazepine in treating the various stages of bipolar disorder has not been well proven, but a few small controlled studies suggest that oxcarbazepine is effective in acute mania. Other studies suggest the drug may also be effective in maintenance phase of bipolar disorder. So let me just do something quickly right now for again, because this book is like from 2017 or something like that. So let me read about this right now. So what is it used for? So oxcarbazepine is an anticonvulsant medication primarily prescribed to prevent and control patient-onset focal seizures in adults and children with epilepsy. It works to stabilizing the hyperexcited nerve membranes and calming overactive electrical activity in the brain. It's used for partial seizures, and it can be used for off-label purposes like for nerve pain, like in trigeminal neuralgia, or in bipolar disorder. Or it helps stabilize manic or schizoaffective mood episodes in patients who haven't responded to traditional treatments. So it's like an off-label purpose for those two things. It's sort of similar to what carbamazepine is like, because again, it's similar to that as well. And so it can also be used not only for seizures, but also for bipolar disorder and for trigeminal neuralgia potentially. Let's finish this up. Antipsychotic medications and bipolar disorder. Several atypical antipsychotic medications, Chapter 11, are also approved for the use in bipolar disorder. Atypical antipsychotics approved for the mood component of bipolar disorder include olanzapine, quetiapine, I should say. I've been saying quetiapine for a long time. It's probably more accurate to say quetiapine. Risperidone, ziprasidone, and aripiprazole. They can also be used as a monotherapy or in conjunction with traditional mood stabilizer to achieve more optimal mood stability. And that's the end of the body of the chapter. Let's do some key points now. So what is the take-home points? Mood stabilizers are indicated for the treatment of all episodes of bipolar disorder. Mood stabilizers work by unknown but likely varied mechanisms. Hint, hint, we kind of know to some degree. Certainly not, more so now than before, but still, we had a decent hint about what was going on before. Just not, the whole thing is not totally fleshed out, I guess you could say. Effective treatment is achieved through daily dosing at a therapeutic blood level. Mood stabilizers have serious toxicities, so patients require regular monitoring. Some atypical antipsychotics also have mood stabilizing properties and can be used as monotherapy or in conjunction with more traditional mood stabilizers. And that is the end of our chapter 13 on mood stabilizers. So hopefully you found that of good use. If you stuck along through the whole video, hopefully it was of good utility to you. Otherwise, have a great rest of your day. Thank you and goodbye.